Dear international colleagues, dear food members, I would like to invite all of you, our international diabetic food team, to join our webinar, which is related with diabetic food problems. And we are all together all over the world. And within this week, we are together with our patient with diabetes and diabetic foot ulcer. The webinar consists of 5 presentations dedicated to those patients and the new perspective of diabetic foot patients, which will be opened thanks to our activities. As the first of our presenters, I would like to ask Dr. Abbas, the president of Diabetic Food International, who exists for more than 50 years and engages people all over the world to make the life better for our patients. Dr. Abbas, the floor is yours.
It is an honor and privilege to address you today as President of D-Food International. I speak not only to the diverse and vibrant individual present here today, but also to hearts and minds of millions worldwide, united by a common cause to combat diabetes-related food complications. D-Food International is an organization consists of people working in the field of diabetes-related food complications. These people are spread across 7 regions in the world: Sub-Saharan Africa, South and Central America, Middle East and North Africa, North America and Caribbean, Europe, Southeast Asia, and Western Pacific, all dedicated to providing preventive food care for people with diabetes through awareness, education, and professional guidance. The looming global diabetes epidemic is a step reality, projected to rise with the highest burden in low middle income countries. As diabetes rates surge, so does the incidence of diabetes related complications, including food related complications, which is our focus of action here at D-Food International. Our mission of D-Food International is resolved and clear, ending avoidable low-limb amputation due to diabetes worldwide. It is not just a vision, but a mandate, a call to action demanding our utmost attention and urgency. We should all unify our goal and aim for a 50% reduction in limb amputation rates by 2026. In this mighty ambition, education and the empowerment of healthcare professionals are our only weapons of choice. As I often say and will continue to say, education is only powerful tool we have. Education is power, especially in the low middle income countries, where it is free and immensely effective when properly implemented. It is noble pursuit. We at D-Food International are proud to see the happenings of Diabetic Awareness Week campaign. This campaign, we find each one of you as a faithful ally in this great endeavor. The success of D-Food International goals depends on your patience and efforts for educating communities and obviously raising awareness. Diabetes Awareness Week campaign is one of the flagship program of D-Food International. As every year, this year we'll have programs in all the regions starting from 7 to 14 November. We have one day allocated for global meet where all the regions come together on one platform. Today, I invite every one of you to picture a world where every healthcare professional is prepared to offer knowledge and skills to provide specialized food care. Imagine a nation where stigma attached to preventable amputation is eliminated and a gap between affordable and accessible diabetes food treatment is permanently addressed. Coming closer to the end of my short introduction, D-Food International extends a hand of collaboration to every one of you. Let us work together to promote care of diabetes-related food complications and their management, making it financially feasible and increase awareness about it. Lastly, I would like to personally thank everyone present here today for being part of this noble cause. We look forward to the impact we can create together. Thank you so much. Thank you.
Thank you very much, Dr. Abbas, for your presentation. We would like to thank you personally for your work you do all over the time. And for those who do not know, that Dr. Abbas did something which was absolutely impossible to do. It was a mission impossible because in Tanzania, he organized about 50 centers of diabetic foot and lowered the rate of amputation for more than 50%. I believe that thanks to such people like Dr. Abbas, we could change the world of people with diabetes. Now we would like to come across other countries in Europe. We are the countries of different origin, of different perspectives, of different financial possibilities. That's why we would like to show you how we can manage to start to change the organization of care of patients with diabetes in different European countries to become the Europe of one speed. Now I would like to show you what we are trying to do in Poland, and then we will travel to Italy, then to Slovenia, and then we will go to the Europe Parliament. We will come to Dr. Adam Jarubas, who will show us how do they, politicians, look into the problem of diabetes, what they would like to do, and how to change the real perspective of patients who are living now in Europe. So, ladies and gentlemen, we are now in Poland, and this is a country which changes within last years, and we are very actively working people. That's why the number of patients with diabetes is growing up day by day. And as you see in the title of my short presentation, stay and stand on both feet. And we would like to share the formula we sent all over the world to share your experiences thanks to this survey, and to compare the possibilities of patients all over the world and change their perspective, their possibilities, and to give the possible and comparable possibilities to every patient with diabetes. We are together in 5 people, but of course we would like to have the representative of D-Food International in every country, and each of us will try to share our knowledge, experiences, activities to other people who will form a net of people engaged into this process. And today in Poland we survive the Diabetic Food Awareness Week, which starts today in Poland and exceeds into 16th of November. But of course, people could come every day because we know there are not enough of centers which are dealing with them. And just an hour ago, we discussed this problem with people engaged into this strategy. And we said that we have not enough of power to show our politicians that there is a huge problem. And I would like to show how does it look like. Today, many people in many outpatient clinics could come into the centers which are conducting this campaign, and they could come and answer several questions, and then they will be examined, and after the examination they will be put into one of the 4 groups depending on the risk which they have, the risk of diabetic foot. And we know that many years ago there was prepared a special formula which was categorizing the patients into 4 categories depending on their risk. And all those patients which today will come into those centers will be divided into the separate risk, and the patients will be told, you have to do this, this, or that, or perhaps you are in the group of the highest group and you have to be sent into the hospital. You could see the questions which are in the questionnaire, and those questions are related into the both whether the patient was under the care of the patient, whether the doctor checked the pulse, checked the symptoms of neuropathy, or whether the patients could help himself if the features of the wound comes. We would like to compare diabetes into other cardiac problems. Within last years, many activities were done for patients with cardiac diseases, with cardiac infarction. And as you could see in this map, Poland is one of those countries where patients could come and without any problems could be helped with cardiological problems. If we compare it with the problem of patients with diabetes, it doesn't look like. And we would like to change this landscapes as quickly as possible. And we would like to compare the problem of patients with diabetes with the problem of the patients with a cardiac infarction. Because if the patient has a necrosis in the foot, it looks like to have a foot attack. But why we do not treat those patients as the patients who have a foot attack, really? We know that very many of them who have the foot like that, you could see in the picture with the necrosis, with the black necrosis, they are of the very high risk of myocardial infarction. So generally, the patient with diabetes has to be treated more or less as the patient with a ischemic heart disease. So if we have the patient like this, we have to treat them more seriously than was until this moment, because these patients could die due to sepsis, these patients could die due to MI, and this patient could be the features of infections in other parts of the body. The problem which we are facing is the problem that the age of the onset of diabetes is decreasing. And nowadays in America, they stated that about 50% of young children up to 10, they have diabetes type 2, not type 1. So we are facing a real epidemic of obesity and diabetes. And we have to know that those patients who start to have diabetes in the age of 10, for example, will have MI having 20 or 25 years old. So this is a real big problem. And if you have a patient who is, for example, 30 or 40 and has diabetes, his arteries look like having much more. So being 60 or 70 years old patient. So it is usually a real epidemic with no viruses. And the patient with diabetes has to be in the center of many other specialties. It is not the only diabetologist or endocrinologist who is taking care about him. They have to be under care of vascular surgeon, of cardiologist, nephrologist, neurologist, psychiatrist, psychologist, has to be treated by orthopedic doctor. And there are many other specialties, just like the nurse with podiatrist, podologist. He has to be taken under care of the nurse, educational nurse, social worker. So there are many other people who have to care to have the final success of the patients. While looking into the countries in Europe, you could see that the ability to come into the professional center dealing with diabetic foot, it is not so easy. I remember being in the Germany many years ago when we were in the center dealing with Charcot foot. There were only several in Germany which could professionally treat this kind of patients. So we have a lot to do still. There is a problem even if we are in Europe when we have many people dealing with many other aspects of diseases, of many health problems, but not only. And we would like to knock the door of European Parliament to give them the real situation of our patients. Theoretically, we know that the patient with diabetic foot has to come into the minimal model clinic, yes, so the clinic which is taking care with the basal model within 2 weeks. And if they fail, the patient has to come into the intermediate model, diabetic foot clinic, which is dealing with most of diabetic foot aspects within 1 month. But if fails, then comes into the Charcot complex revascularization, whatever. So it is a reference center. How does it look like? We ask our patients, they wait something for 2 or 3 months or even sometimes longer. There is, of course, a question of the organization of care of those patients. Of course, if you don't know where is a problem, you know the problem is with the money and those patients usually are helped with the public care and private access, both. And sometimes the patients comes to the clinic and say, great, but I can't afford to pay or to wait. So we are looking into the table, round table, to the round table, which is managing healthcare reforms and trying to show them that they could also become a patient with diabetes and those problems. One of our surgeons calculated that the cost of 16 amputations is equivalent of the 120 ulcers being healed, or 834 people in whom we started with the prevention. When we are looking into the directions of the development, what are the strengths and the weakness of the system? In most of our European countries, there is a good housing base. We have clinics, we have education, and we have consultations. Or we have possibilities to create a food clinic. In some of them, we have multidisciplinary teams, but not in all of them. But generally, we have a good team cooperation because we cooperate together. And there is a wonderful device, which is a mobile phone. You can call to your colleague, but this is not to solve the problem. So what are the weaknesses? There is a limited availability of services depending on the country. In Poland, we have the problems with financing systems, and within 3 days, we will have a big debate in our Ministry of Health how to change the system of funding procedures. That's why, because there are not enough of places the patient could come and be treated specially, there is a problem of waiting for the appointment. So if patients are waiting too long, they are failing, the time is being wasted, and we are wasting tissues, we are wasting legs. The same problem we have with the vascular surgeons when there is a too long time for the revascularization procedures. I think the problem of orthopedic doctors is all over Europe and not only Europe. There is a lack of orthopedic facilities. What we discussed within an hour, there is a lack of financing for full therapy from the National Health Fund, and there is no reimbursement in the diabetic food for saving the food. And there is insufficient knowledge among surgeons about the principles of diagnosis, differentiation, and treatment of diabetic foot ulcers. Unfortunately, unnecessary or premature amputations. What are the chances? There is rising of the awareness of healthcare providers in the National Health Fund. There is rising patients' awareness. There is higher knowledge of doctors about the standards of care, but we do not follow instructions and standards of care. We could create a network of diabetic food clinics which are opened for the standards. What are threats? Still, there is further limitation of services in the treatment of diabetic foot ulcers. There is still a small number of clinics dealing with it. There is a failure to comply with standards in those centers, and further failure in promoting diabetic food methods and clinics among primary healthcare physicians. If you look into the possibilities of telemedicines, we know that thanks to the COVID infection and epidemic, this method of treatment and diagnosis is enlarged. It is increased incidence of diabetes and 90% increase over the last 10 years, and the lack of proportional increase in the number of diabetologists and diabetes nurses. There is shifting the burden of care to primary care physicians. There is lack of time for education. And if you calculate what is the time for the visit, it is usually around 5 to 10 minutes. So there is lack of time for education, not having time for enough visits. And diabetes treatment goals are not being achieved, that's why. And there is increased expenditure on the treatment of complications. If you look into the ideological care scheme, it could be prepared like that. So if the patient come into the door of the hospital, it could be sent from one into the other department, and the patient cannot care what are the costs of the hospital. The cost has to be shared within many departments. And it is just now that we are discussing in our parliament about the procedure which is now followed in one of our hospitals. There is a grant of the Ministry of Health when in Hashamotu, it is a small city, when our doctors started to treat patients thanks to the grant of the Ministry of Health, and there is a very low rate of amputation. It is thanks to the procedure which is both internal and surgical. What is the patient's perspective? We prepared a 5I concept, which means that the patient has to have everything on time. Patients have to have the flow of information, so everything has to be interactive. Patients have to have knowledge, and they have, because they have internet, of course. They have to be treated as an individual person. So the patient has increasing expectations. And of course, everything has to be integrated. We have to have the basis of the data of patients, and we do not need waste of our money to repeat the procedures again and again. So the question is whether we are able to prepare this kind of a strategy to have the patients being dilated, being happy, and having his food. Last summer, we met together with our parliamentaries and the members of the Ministry of Health, and we showed them the effects of this pilot program, which is following now in Shamotuły, and we showed them that it is cost-effective, that both for patients which have food and for the Ministry of Financial Affairs, which have money. So we are as well preparing some campaigns. We started this month, the campaign, The Wounds Under Control. And we prepared the data in the special publication titled Awareness and Effectiveness, What Should the Wound Care System Look Like in Poland? And we gathered different experts from different fields of knowledge, doctors, nurses, pharmacists. We worked together, and finally we prepared a document of the same title, Wounds Under Control, and we would like to work together in this field to change the real perspective for our patients. Today, together, we started with our doctors in our hospital, we started the educational program All Together Against Diabetes. This is the program for patients and their families. And there are very well experienced doctors dealing with this program, and we would like to change the knowledge of our patients to know what kind of problems they have to knock to the doctor, to beat with them sometimes for the real perspective. So all together against diabetes, we have to fight all together to change the landscapes of diabetes and the perspective in not only Poland, but all over the world and Europe especially. So together we are stronger. There is a picture we took 2 years ago in a very small city called Kazimierz. It was in Poland during the diabetic, our Polish Wound Management Association Congress. And as you could see, there are many different specialists. The lady who is signing the document, she's a nurse, She was the head of the nurses association. And there are other people, you could see Professor Yavin, who is a vascular surgeon, and many others. All of them signed this document to do all the efforts to change these landscapes. And we signed, the health community, declared our willingness to take comprehensive measures to change in the incidence of complications caused by hard-to-heal wounds, including mortality and other sequelae, such as limb amputations. And what are our strategies, what we would like to do, and what we did within this time? First, we were together during different conferences, WHO, IDF, EASD, Asia Pacific Association, on Diabetic Limb Problem Conference, UMA Annual Conference. So we are informing the medical staff. Then we and I will show the picture within a moment, we discussed with IDF and we signed the declaration to do our efforts to change this perspective for patients thanks to the activities of IDF. And now, and there's exactly this picture from the last months. This was taken, this declaration together between IDF and the Food International, and we are waiting and we are knocking now to Europarlamentaries and Brussels and to look into the patient's problems, look into the global epidemic of diabetes and the complications. And we are waiting to change the priorities of the European Union within last decade to see that the problem is a real huge problem we are facing. So now together we are stronger, and we believe that thanks to your activities, all of you which are here, our distinguished guests, and thanks to all of you listening to us, we can change this perspective. And why? Because together we are stronger. Thank you so much to be with us. So there is a time for change, and this time has come. There is a call to action. We could go everywhere. We could go into the space. We could go into the moon, and not only to the sun yet. And we hope that we could meet together during the next Congress, which will be held within 2 days from 5th to 7th of June next year. And we invite all of you to Poland, to the small city near Warsaw, Wachów, and we hope we could sign this declaration there all together. Thank you so much. And now I would like to ask Professor Vilma Urbancic. Oh, there's a Professor Roberto Anichini from Italy, who will show us how the Italians would like to change this perspective of patients with diabetes and what is Italian way of doing with this problem. Professor Roberto Anichini.
Thank you. Thank you, Beata, for your presentation. I'm very pleased to discuss with you, with the other part of Europe, about the food. And thank you for all participants, and thank you at the name of Diabetic Food International to participate to the discussion. We have a different situation in Europe, even if we are not income countries. We have changed economical aspect. We changed a political and socio-economical aspect, and then we can try to put together a different aspect to improve our aims. Now, okay. No, sorry. Is the last. Okay. Sorry for this remain Okay. Sorry for this problem. Okay, my topics today I speak about a story of diabetes food in a part of Europe, and especially of amputation. You know that many years ago in Saint Vincent, with the declaration, Saint Vincent is a regions of Italy. We tried to give objectives to diabetes food to reduce a 50% the number of amputation. And our mission as the Food International is we discuss all together in every part of the world, ending with avoidable low limb amputation due to diabetes. When I prepared my presentation, I talk about what does it mean today, this motto. Of course, especially in Europe, means some things. A global approach to improve diabetes take care and assistance, not only diabetes food. Now we have a new therapy, a reduction that we can improve, a reduction of chronic complication of diabetes. And then we can have a really primary prevention of food injury and management of ulcer, and then to create organization and assistance spread through the all part of our territory in our country, in my country, in every part of Europe. And finally, a team approaches of palliative care for patients with diabetes and ulcer of food risk. And today, a modern mission of diabetes food to improve our outcome is early take care of patients, a fast-track strategy, and improve motto, time is issues everywhere. Here is Italy. Italy is with this inhabitant, with this prevalence of diabetes, and with about 300,000 patients with diabetes. And here is historical data about the approach after a Saint Vincent declaration of diabetes food. Sorry. Sorry? 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 I have not came back. Is correct the presentation?
The presentation is not seen at this moment.
No, sorry. But if you don't, you did not speak me, it's very difficult that I go away. Okay. Sorry for this inconvenience. I'll try to. Sorry.
If you have it opened, you have to share.
Yes. Did you see now?
Not yet.
I have a problem maybe with the line. Sorry, I close all connection and then.
So Roberto, you could follow without slides because your stories are very interesting. So perhaps we could follow without slides. Or otherwise we could ask Professor Vilma Urbancic.
Yes, maybe it's better. Sorry.
Yes.
But I have no line. Okay, 5 minutes. And
If you prepared.
Okay, okay, okay.
Okay, so now we will ask Professor Vilma Urbancic because for showing us the other way of doing. So how do they do in Slovenia? And how do they solve the problems related with diabetic food? Professor Vilma Urbancic, the floor is yours.
Thank you, Beata. Thank you very much. I enjoyed your talk, and I enjoyed the beginning of Roberto's talk, so I hope he will be able to show his slides. I'll be talking about the situation in Slovenia, but of course, I will not go into detail because it feels as if coming to Slovenia, asking what should be seen, and knowing that you only have 3 days, then you have to choose 3 top destinations which you want to see with no ambition to see the whole country. But before going to these lovely places, I would just summarize the history of diabetic foot care in Slovenia in the last almost 35 years. It was in the early 90s when we started, so when the first foot clinics were established. And in 95, the National Working Group on the Diabetic Foot was set up. In the same year, we organized the first training course for nurses, and in 96, screening test was set up and implemented in the foot clinics. In the years which followed, we have set up a network of outpatient foot clinics, but we have also participated in the international activities, most important of them being participation in the guideline development, then founding of Diabetic Foot Study Group. I'm proud that we have participated in Eurodiali and so on and so forth. But maybe one of the important things is also that in the year 2005, when the World Diabetes Day was dedicated to the diabetic foot, Slovenia was named a success story in this field. Anyway, maybe the thing most important for building up efficient diabetic foot care countrywide is preparing a national strategy, which you can see here on the slide, and we have developed it in a step-by-step way so that everything begins on the primary healthcare level, which of course should do the basic preventative and basic curative activities. And to make this possible, we have long ago established so-called model practices. These are outpatient clinics where the nurses with additional knowledge, additional education work, and they are, of course, educated how to perform the basic foot prevention activities. The next step is the secondary level, which provides more advanced services. And of course, we also have the tertiary level, where also research work is performed. But now, as I said, I would like to take you to maybe the top 3 destinations in the level of diabetic foot care development, or at least, if not the top 3 destinations, but the things which I find most important, most significant at this moment. And the first is prevention or early detection of the patients at risk. We all know what international guidelines recommend. The guideline says that every person with a diabetes should have his feet examined annually for signs or symptoms of loss of protective sensation and PAD to determine if these people are at increased risk for foot ulceration. But of course, this is theory. These are good wishes, good ideas. When we come to real life, like our outpatient diabetic foot clinic in Ljubljana, then the situation changes a little bit, because we only have, as you see, 2 full-time and 1 part-time nurse, 1 physician consultant. Of course, we have to carry out not only preventative activities, but also we need to manage the patients with foot ulcers. And we need to do teaching, and we are expected to do the research. So, as the catchment area of our clinic means that we are dealing with almost 10,000 patients, that would mean if we wanted to screen everyone at least once a year, we should do 36 examinations on every working day, which of course is mission impossible. As I said, we have been doing the screening since the year 96. And the important thing, something which we are proud of, is that we have not only recorded these screening tests on paper form, but also in a computerized database as an Excel file. And now that we have the data, we have analyzed this data. It's important to know that we do not overdrive the previous entries. So we keep first examination, second, third, and so on. So as many times as the patient is seen, everything is recorded. And you can see that through years, the risk status changes significantly, and in the end, all the patients end as the highest category, so at high risk. And when we look at the statistics, how many patients who are screened have foot ulcers, you see that the number of them is increasing with time. So what could we do? We have one of our colleagues who is interested in statistics, in computer sciences, and together with a statistician, they developed a prediction model. Why? What was the aim of this? On the basis of this model, it's possible to identify those patients who are really at higher risk and who really need to be seen once a year. On the other hand, we can identify those who don't need the screening so often, and this can potentially reduce the number of screenings needed in those who are considered at low risk. And it's close to real life. It makes the work for the nurses and for the doctors easier. Okay, then that was Ljubljana. Then we move to the second interesting destination, which is Bled. Many of you have been there. And with Bled, I would like to describe data management. So I have told you that we keep a computerized database. It's an Excel file. But of course, our patient records are not in an Excel file. We have a hospital and outpatient clinic information system, which contains all the data on a certain patient. But to pull the data of the screening procedure into this database, this has still not been done. So if we want to know everything about the foot, we have to analyze the Excel file. And it's not only the Slovenian problem, it's a universal problem. You know, IDF says that international databases which would use similar definitions should be set up because we want to have direct comparisons between and within countries. And how could that be done? Again, we are currently involved in a project which hopefully would make a step toward overcoming the problem of the Tower of Babel, when the people all of a sudden have their tongues mixed, so they were speaking different languages and they would not understand each other. We would indeed need one single language which everyone would understand. This is the idea of this. I'm not an IT specialist, but fast healthcare interoperability resources. This is an international standard that provides a set of base rules for exchange of data. I hope that something will come out of that so that we can use the data from different countries and compare and to make some benchmarking. And then the third day, we have another beautiful destination. I would choose Postojna Cave. And with Postojna Cave, I would describe the problem of who can do the work, or in other words, we have for many years been discussing about how to do the diabetic foot care without podiatrists. We know that not all the countries in the world have licensed podiatry education, and many attempts have been done towards improving the situation, towards filling the gap, like step by step, train the foot trainer, diabetic foot care assistant, or point project. Last year already, I have said at this point a few words about an initiative from Slovenia. We tried to classify foot care by types, and also we tried to define the competencies of particular profiles who offer these services. And we have prepared this classification of foot care pedicure. But of course, if we want to do the higher levels of foot care, we need someone who would be properly trained to do it. And I'm proud to tell that since the year 2025, we have an official podology study. You would say, okay, great, you managed it. Yes, we managed. The only problem is that this study program at the Faculty of Applied Sciences is not a part of University of Ljubljana, and so it cannot be done for free. It's a payable program, so the students have to pay the costs of the study, which is, of course, a barrier, quite a big barrier for many of them. Anyway, another point I would also like to mention in connection with this study program is that the programs which provide the knowledge on podology should be verified and accredited on every particular level. And also accreditation, it's not just about the credit points which are done on the basis of the number of hours and on the contents. it's also the faculty which organizes it. But anyway, of course, this is a challenge. But I'm happy to see that every generation which enters the study is better. Of course, you cannot make good chocolate from poor quality cocoa, but as I look at the students who have enrolled this year, I feel that they are motivated, and I hope we are going to get good podologists. And that's about it. Of course, it's much more easy to make Slovenia in 10 days. You can make 10 perfect days in Slovenia, and I would have many more things to show you, but maybe these three, which I have chosen, are something which is not very typical. It's not an everyday job, but something which could make us think. Thank you very much.
Thank you very much, Professor Vilma Urbancic, and thank you for showing us the methodology, how to deal with those problems. I hope we will ask you to check to gather those data together, and perhaps to form the new Eurodial or whatever, to show the actual data on this problem. So thanks to our knowledge and your experiences, perhaps we can help other countries as well. I would like to ask Professor Anichini whether he is ready with his presentation now. Oh, yes, happily.
I hope that now is okay.
Thank you very much. So, Professor Anichini,
Sorry.
the floor is yours now.
Try to start again. We remain at this slide. What means today a handling evidable lower limb amputation with a today modern vision to hardly take care a patient, a globally patients, a whole patients with diabetes. Here is the point. Here is Italy with inhabitant diabetes mellitus prevalence and a patients with diabetes foot. And here is the story, the historical data. I remember you that San Vincent Declaration has been published in Italy. And at that moment, we began to implement international consensus on diabetic foot, identify a typical aspects to improve diabetic foot care. Here is my old study where, for the first way, we speak about education of all part GPs, nurses, all part of healthcare district, a rapid identification of ulceration risk by the healthcare district, and then a new team in the hospital all together to against the battle against amputation. In this way, we reduce significantly a number of amputations. Here is the data of amputation in Italy in the last, at the beginning of the third millennium. As you can see, we had a significant reduction of number of amputation. And if we look at this data and the data of the other 10 years later, we see that in every part, here is the data of Organization of Economic Cooperation and Development that put the attention of a number of amputations in the world. As you can see, in the world, in that period, we reduce in that countries a number of amputations, and about the 30% of major amputation. But as you can see in this paper, Italy remain a country where they with the lowest rate of amputation in comparison with other countries. As you can see, we are a very different number. Also in income country, but also, for example, in Israel, in Germany, in France, or in Netherlands, in comparison, for example, to Italy or to Korea. So means that we have a different approaches about amputation, about take care patients with diabetes foot. Here is the result of recent years. Here is 2015 in the 2023. As you can see, we are two aspects. A constant reduction, also slowly, of number of major amputation in Italy, but also a big variability in a different place of Italy. So means that also if we have a guideline or a common approach, we have a different aspect, a different number of amputation, and we need to understand why. Here is a national results. Here is a results of a different regions in Italy in the last 3 years. As you can see, the same aspect, a slow reduction of major amputation, but a very different in a different region. So here is the first our data. Major amputation have decreased in the years, and the significant regional variability persists despite the common treatment and the guideline. I'd like to remember you what means diabetic foot ulcer. Diabetic foot ulcer means this stage for the first event to recurrence. And if we don't approach all these aspects in a good way, we have a high risk of amputation or a high risk no healing ulcer. What is a theoretical and clinical aspect today, not 20 years ago, to approach diabetic foot? To approach diabetic foot, we need to approach with a holistic aspect a global diabetes patients. Because we know that diabetic foot is a syndrome, but not only an ulcer. We all together, all part of diabetes complication, cardiovascular disease, kidney disease, cerebrovascular disease, and so on. Together with we know that a big part of our patient is very healthy and is early and have also a frailty situation. And there, the point 3, 4, and 5, the 3 aspects to take care of our patients. What is our organization? Why these results? For Italian health organization, I remember that diabetes is, and we have a universal approach to healthcare. And we have a diabetes foot organization with a different level of care. We have a network between diabetes foot and diabetes foot unit to improve our outcome. And finally, we have a multidisciplinary and multi-professional approach with the foot organization. Here is a recent paper of Italian Diabetic Foot Study Group, where we put together all kinds of messages that for healthcare organization to improve and take care of patients of the diabetic foot. For example, of course, action to a patient and put together different aspects, healthcare district, hospital team with the vascular team, the surgical team, with the rehabilitation team. So, all together to take care of patients with diabetic foot. Here is an example. On the right, a patient-centered quality, and the other part, a quality-centered of healthcare organization of diabetes food. We have to consider that today, patients with diabetes have a big opportunity to change his medicine, is take care with a new approach, a pharmaceutical approach, and a global approach to a single situation of diabetes, early aggressive metabolic control, risk factor control, and the other aspect of a global approach of diabetes food. And finally, on the right, you can see a other part, the other aspect of healthcare organization for diabetes food. I remember some minutes ago, a team approach, a time is tissue, every time, everywhere, a fast-track strategy, and the comparison with the benchmarking in a different region. Why? In one place, we have more amputation in comparison with the other to improve, not to give a negative judice, but to improve a way to take care of our patients. So, a positive results in Italy for this aspect, and one important aspect is a connection with diabetes unit in general and diabetes food on the left, on the right, diabetes food unit. With this connection, we can try to approach a whole patient, but especially a patient with diabetes food. And the connection, the key words are a pathway of care of our patient, with a patient-centered, with a specific pathway of care and organization of different level of care. Here is some flow chart for diabetes food care. As you can see, it's not important to look into this pathway. You can see that all parts of healthcare organizations need to stay together and to introduce with the to participate of this aspect. And now, so we know how, what, and where we can do what we need. A specific aspect, an important aspect, is the take care healthcare district. The problem of widespread hospital, where nurses, podologists, podiatrists, GPs, education, physiatrics, and so on, all put together to understand a risk monitoring and immediate intervention, and so we translate a concept of take care of patients, of a time is tissue, of a fast-track strategy, integrate reference, diagnosis, share care plan, and monitor a continuity of care of our patient. Of course, then a hospital team, of course, that we know, interdisciplinary collaboration, and finally, a rehabilitation prevention team. When I spoke some minutes ago about a natural history of diabetes food, one important problem is recurrence. Recurrence means that some patients that arrive in the hospital at the healing their ulcer, then for many reasons that we have to analyze, nearly have a recurrence of ulcer. This is a central point in all kind of pathway to understand why a patient that before he healed the ulcer, then newly ulcers make a new ulcer. So, what is our philosophy to use our pathway that give us the opportunity to have a good outcome in comparison with the other country. We need to raise awareness of the risk with diabetes food. That diabetes food is not only an ulcer, but a medical change, and the necessity that without appropriate and early management of all parts of pathway, we have not a result on the outcome. The problem is always, in every part of our pathway, is a fast track and time issue, because of course, when we have this kind of situation, it's impossible to have a good approach or have a good outcome. So we need to arrive before. Arrive before means to looking for a situation, a risk class, and a beginner lesions. Here is a classical fast-track pathway of D-Foot International. And finally, I want to put together this aspect of fast-track from a patient selection, a characteristic of patient, and a different approach of different lesion in different patients. So our idea, our motto means to have in a whole patient a pathway of D-Foot oriented that put together the knowledge, skills, behavior of all participants of our team to activation awareness, diagnosis, prescription, adherence, and continuity of care. In this way, maybe that we can improve our outcome. So, finally, a final suggestion about amputation. We know that until now, we consider a quality of care as consider the amputations a quality of care. And we have to understand if the amputation a quality of care or a progression that a pathway to amputation that became a quality of care. We know that if we want to reduce the number of amputations, we have to understand the change of our population for age, for a vascular condition, and maybe for a new therapeutic approach. And sometimes we have also to understand if a person did not have the ability to work in the future, and the quality of life of patients with ulcer is so hard, especially for the age, that we can also change, never amputation, but it's better to do what is needed for the quality of care of our patient. Thank you for your attention, and sorry for some minutes ago when I had a problem with my presentation. Thank you.
Professor Anichini, we would like to thank you very much for your presentation and showing us the philosophy of Italians, how to do with diabetic foot. And I believe if we will combine your philosophy with the precision of Slovenian people, we will manage with diabetic foot, and perhaps we can create a new model which will be able to be seen, to be finally shown in Euro Parliament, and we will be able to prepare a new perspective for our patients. It is my great pleasure to announce the lecture of Professor Adam Jarubas, who is the head of the Health Commission in Euro Parliament. And I would like to thank you very much that you agreed to be with us. It's a great honor for us to have the member of Euro Parliament so important for the health issues. And I would like to ask you about many things, but first we would like to know what is your perspective and what is your vision on the problem of diabetes, its complications now in this time, this period of Europe. Thank you very much, Professor Jarubas. The floor is yours.
Thank you very much. It's an honor to me to be with you today. Thank you for the opportunity to speak on the Parliament's vision in the area of counteracting to the development of diabetes and its complication at this seminar by the Polish Wound Healing Society, the Polish Diabetes Association, and the European group D-Food International in the week of World Diabetes Day. Europe spent more on diabetes in 2023 than all the EU funding donated to Ukraine since the Russian invasion. The prevalence of diabetes, particularly the largely preventable type 2 diabetes, is rising at an alarming rate, driven by factors such as obesity and an aging population. The annual cost of diabetes in Europe is limiting European economic growth as well. As we know, diabetes is one of the most common non-communicable diseases. There are more than 33 million people in the EU living with diabetes, and the number of people living with diabetes in the EU is predicted to rise to 38 million by 2030. Non-communicable diseases such as type 2 diabetes, obesity, and endocrine disorders increasingly affect children, which requires a dedicated approach to prevention and management. And many people living with non-communicable disease such as diabetes are often undiagnosed or diagnosed very late, thus leading to devastating complications, as rightly stressed by the Food campaign or a work of Diabetes International Federation, vision loss, kidney failure, and ultimately death, including through cardiovascular disorders. Another rising acute challenge, which is the leading issue of today's meeting, is diabetes-related food complications, so called diabetes or D-food, often now and at younger age globally, and the resulting increasing number of amputation, often premature, due to this condition, especially in low and middle income countries. The annual cost of diabetes in the European Union is massive, including around 104 billion euros in healthcare costs and 65 billion euros in productivity losses. Fortunately, the great majority of this cost can be prevented through diabetes prevention, what you mentioned, early detection and good management of this disease. We have a chance to achieve this by among rising public awareness. Recognizing the urgent need to address this crisis, it is important on the eve of the World Diabetes Day to reflect on the actions that the European Parliament has taken to address the issue of diabetes. I would stress two main actions of the European Parliament, one on diabetes and the other one, non-communicable disease. On the 23rd November 2022, the European Parliament adopted a resolution on prevention, management, and better care of diabetes in the EU on the occasion of World Diabetes Day, which urged the Commission to take action. Among others, this resolution called for member states to develop and implement national diabetes plans, ensure equitable access to treatments, and promote diabetes education. The resolution also emphasized the need for stronger EU leadership and collaboration with member states to achieve these goals. The resolution also called on the Commission and the member states to demonstrate political commitment and set ambitious targets for reversing the rising trends in numbers of Europeans with diabetes, to reduce inequalities between EU citizens and improve the care and quality of life of people living with diabetes. Following this resolution, written questions was put to the Commission in May 2023, to which the Commission replied by stating that diabetes and reducing lifestyle-related risk factors are part of the Healthier Together actions, which are funded under the 2022 EU for Health work program. In this regard, this includes a joint action with a budget of 53 million euro addressing diabetes and cardiovascular disease. A further 75 million euro is dedicated to another major joint action on health determinants to prevent cancer and other non-communicable diseases, including diabetes. Two further joint action related to diabetes are being implemented with a budget of 7 million euro under the 2021 EU for Health work program. Furthermore, under the 2022 EU for Health work program, a call for proposal on non-communicable disease, cardiovascular disease, and diabetes with a budget of 5 million euro, and another one with a budget of 8 million euro on addressing related health determinants were launched for stakeholders. On the 13th December 2023, the European Parliament adopted a resolution on non-communicable disease, which reinforced the need for a coordinated approach to address diabetes across the EU. Among others, the resolution stressed that some non-communicable diseases are closely linked, such as diabetes and cardiovascular disease, and that important synergies can be achieved by improving diagnosis and integrated care in collaboration with local social and community services, as health and social needs are often intertwined. The resolution also noted that an unhealthy diet, as well as some perfluorinated and polyfluorinated alkyl substances, FAS, can lead to serious medical conditions such as diabetes. It also noted that communicable diseases can have non-communicable chronic consequences. Another action where members of the Parliament play a role is the interest group of diabetes, MAPS Mobilizing for Diabetes, MMD, which was established in November 2020 and continues to work with the EU Diabetes Working Group. It aims to represent the interest of people living with diabetes, their relatives and carers, as well as those at risk. Mobilizing for Diabetes members work to elevate diabetes on the public agenda and foster key policy change in Europe. Finally, it is worth mentioning that the mission letter for Commissioner designate for Health and Animal Welfare stresses that he is tasked to step up the work on preventive health, ensuring a comprehensive approach to health promotion and disease prevention across the life course. Investing in effective prevention measures will reduce the burden of non-communicable disease, helping to lighten the load on healthcare system and supporting healthy longevity. In her opening speech at the plenary session of the new European Parliament in July, Ursula von der Leyen announced a strategy for cardiovascular disease. As a member of the European People's Party, I'm pleased to hear this because in the campaign for the European Parliament in 2022, in our manifesto from Bucharest, we called for the adoption of such holistic cardiovascular strategy, which will also cover the area of diabetes, including complication. We want the success of the Beating Cancer Plan strategy, which we called for in the 2019 elections, and which has been implemented since 2021 to allow us to build on its achievements, similar holistic, comprehensive strategy in other priority areas of health threats to Europeans. We also welcome the fact that Ursula von der Leyen's mission to the candidate for the new Commissioner for Health, Oliver Varhelyi, also explicitly included the task of preparing, adopting, and implementing a cardiovascular strategy. And when asked about this issue during a hearing in Parliament last week, Oliver Varhelyi explicitly announced that such a strategy must also cover diabetes issue, including complications. I don't want to jinx it, but it is also true that I have convinced the EPP group to submit a question to the Commission with an oral answer and a debate in plenary and possibly a resolution on the diabetes. If we get the support of the majority of political groups for the EPP proposal, we might be able to put this topic on the agenda for November or December plenary. So if you could find the maps from your constituency and write to them, drawing their attention to the need for such a debate in Parliament, it could be excellent. There are a couple main reasons we want to put it on the plenary agenda, apart from the acuteness of the deteriorating health situation. Current international efforts by the D-Food International around the proclamation at World Health Organization that we think the EU should take active part in. A plenary debate and a resolution would be a great opportunity to bring attention of the members of the European Parliament and the public. We believe that the collaborative efforts of global and regional institutions to battle the global burden of diabetes and its complications could decrease mortality and prevent disability associated from the non-communicable disease among people living with diabetes. We also believe that such a plenary debate and resolution would be a good opportunity to update European Parliament's November 2022 resolution by a newly elected Parliament with ideas for the new Commission. Thank you very much.
Thank you very much, Dr. Jarubas, and we would like to thank you for all your efforts in the field of putting the problem of diabetes and the complication into the agenda of your meetings. So we believe it will start to be one of the leading priorities in Euro Parliament soon, and thanks to those activities, we will change the global division of patients and coming into the particular field in particular countries, the possibility of those patients will change. And having you in the here in the screen, we have the other panelists. If you have any questions to Dr. Jarubas, it is a unique opportunity because he is one of the leading persons in Euro Parliament who is strongly dedicated to those problems, because it is really a big epidemic, as you mentioned, and you see this problem and you know that it is really a huge epidemic of obesity, especially. Professor Urbancic and Professor Anichini, do you have any questions to Dr. Jarubas?
Not a question, but thank you for your interest of this aspect. We hope that in this part of, and the part of a new parliament point put a interesting on diabetes and all part of diabetes. In every part of Europe, because we have seen in this week, in this month, that the situation is very, very different. So we need to increase all parts of Europe and they put in the same situation all countries. Thank you for your interesting. And we are trying to speak with our representative in the European Parliament to improve your strategy, our strategy. Thank you.
Thank you, Professor and Professor Urbancic.
Yeah, well, me neither. I don't have any good question to ask, but I would only like to say that I very much admire your initiative. It's very important. It's a big step toward raising awareness on the scope of the problem of diabetes and obesity, because this is really a disease the politicians should be aware of, not only of diabetes, not only of obesity by themselves, but in particular with the complications of this disease, because the complications are something which is costly and where a lot can be done in the field of prevention. So congratulations once again.
Thank you, Professor Urbancic. We are coming into the close to the meeting.
So, Beata, sorry, just a second. There is a presentation by Dr. Abbas that has not been played yet. I would request to play it now.
Can we continue? Can we continue?
Thank you very much, Chairperson, for your kind introduction. Thank you. I begin with the name of Almighty God, who is the most gracious and merciful. Greetings and salams to all. Good morning, afternoon, or evening, wherever you are in the globe. Welcome to our Awareness Day program 2024. I have recorded my talk as I'll be traveling at that time. I'll try my level best to connect from the airport in the beginning of the program, but this event or program will be almost at my boarding time. So sorry about that. We started our Awareness Day program with Africa region on 7th November 2024, and then we went to South and Central America, North America. We had a global meet at all the regions came under one roof on Sunday, followed by MENA on Monday, and today is European region. This is our 6th program from Europe, and today's talk is New Perspective for Diabetes-Related Food Complications in the World. On 13th November, we have Southeast Asia, and lastly on 14th November, Western Pacific region, which will be our last program. Before I start my talk on New Perspective for Diabetes-Related Food Complications in the World, I would like to thank you very much to the organizers, Beata, Roberto, and Vilma, very good friends of ours, and their board members. Thank you very much. Special thanks to Dr. Adam Jarubas for accepting our invitation and be part of this program as representative of EC. You are most welcome, and it is a privilege and honor for us that you are a part of our European Awareness Program. Once again, thank you very much from all of us, and you are welcome. I once again thank you on behalf of our board members 2023-2025. I come from Dar es Salaam, Tanzania, which is at the east coast of Africa. It is a land of Mount Kilimanjaro, Ngorongoro crater, Serengeti, the largest wildlife park, and Zanzibar Stone Town. You are all most welcome. Africa and Asia are two largest continents in the world, which caters the population of 76% of population comes from that region, and 80% of diabetes come from that region. The rest of the world is 24% of the population, and 20% of the world for diabetes come from that. So we have a huge burden in low and middle income countries. If you look at the prevalence of diabetes in this region, and you can see there is a high increase in all low and middle income countries, but Africa is going to lead the world in next 20 years, which is an increase of 134%. The prevalence of diabetes, as I mentioned, is increasing globally. The greatest increase will occur in Africa, and this is because of rapid demographic, sociocultural, and economic transactions. That means we are developing at the cost of health. Look at 20 years ago, we were only 7.1 million in 2000. Next 20 years, we became 19 million. And in next another 20 years, it is predicted that we are going to lead the world, which is not a nice thing to lead, 55 millions, which is 134% increase of diabetes. We haven't finished with communicable disease, and we are adopting non-communicable disease. So we have a huge problem, double burden. As diabetes is going to increase, diabetes complications are also going to increase: diabetic retinopathy, diabetic nephropathy, cardiovascular, and stroke. And what we are going to talk today is diabetic foot, which is 60% of non-traumatic lower limb amputations occur in diabetes patients. Let's talk about diabetes-related foot complications. Worldwide, as I mentioned, there is increase in prevalence of diabetes. Parallelly, the complications are also increased. And out of all these things, food complications is going to be the dreadful complications, which is already a major public health problem, main cause of hospital admissions. And cost, I'm going to talk on the burden of economic burden due to diabetic foot. Cost is not going to be sustainable even by family, relatives, or nation at large. Commonly, we in low and middle income countries, we have an infectious etiology which is associated with peripheral neuropathy or arterial disease. Amputation in diabetes. Gangrene and infections are the most common cause of amputations. True prevalence in low and middle income countries is never known. It will remain underestimated in the literature because our population, 80% of population lives in rural area, which is never reported. Published reports implicate the delay presentation is the main cause of amputations. Most of the patients need amputations who die before even reaching the surgeons. So in 2005, it was a diabetic foot year where we calculated that every 30 seconds an amputation occurs due to diabetes. And when we recalculated in 2017, it went to 20 seconds. That means instead of 2, now we are doing 3. We are getting 3 amputations somewhere in the world to diabetes. That means we have gone from bad to worse. 1 minute, 3 amputations somewhere in the world is happening. So it's a huge problem. Global economic burden of diabetes related to food complications in 7 regions. Look at the background. USA expenditure on diabetes was estimated about 237 billion in 2017, with 30% of being attributed to diabetes-related food complications. In the UK, has been calculated that 1% of the entire UK budget, NHS budget, has attributed to diabetes-related food complications. It is also reported that 6% of national health budget for Barbados was allocated to diabetes-related food health complications. Brazil study showed that millions are spent on outpatients and similar to inpatients, which are related to diabetes-related food complications. So in low and middle income countries, data on the financial burdens are very less, despite the report says it's high prevalence. In 2012, costs of studying diabetic foot ulcers in 5 countries, Chile, India, Tanzania, China, and USA, 3 continents were done. In 2023, we expanded this study to 7 regions, namely all Africa, Sub-Saharan Africa, Europe, Middle East and North Africa, North America and Caribbean, South and Central America, Southeast Asia, and Western Pacific. The aim of this study was to evaluate the cost across the world in 7 regions of treating 2 hypothetical wounds at a different severity. So we gave them a tool to evaluate the cost across the world of these 2 hypothetical wounds of different severity. The first one, which you see here, is a neuropathic ulcer, and this is an arterial ulcer. So we got a total of 36 countries, 51 centers globally, from all the 7 regions. And these were the mean cost of treating the wound. And you can see that in Africa, the mean cost of treating wound, 2,000, approximate 2,400 US dollar, and cost related to NACA, that means North America, which approximate was 0.06 compared to what you have in North America, which was about 41,000 US dollar. And average annual salary in sub-Saharan Africa is about 1,113, and it comes to about 30 average time to cover the cost salary. 30 months salary is the cost. Let's look at the Europe, which is your region, where we saw the mean cost of treating the wound was 17,600 US dollar approximate, which was approximate about 7.5 months salary of that individual. And this is still was about 0.3 cost relative compared to America. So global epidemiology of diabetes-related food complications in 7 regions are as follows. It's a huge burden, as I already mentioned. The prevalence rate all over the world is about 6.3% of diabetic foot ulcers. 19 to 34% of people with diabetes will develop an ulcer in their lifetime. 70% have got a recurrence in 5 years. 40 to 6% across the globe end up with non-traumatic amputations. 85% of them can be prevented if proper implementation is taken. If you look at the North America and Caribbean region, North America had the highest prevalence of 13%, USA was 13%, Canada followed at approximate 15%, and the major cause of hospital admissions. That's the most highly facilitated centers. Caribbean was found to be the highest rate of amputations due to diabetes. Europe, 5.1% average, and the Belgium was the highest prevalence, which came to about 16.6%. Western Pacific, 3%, and Australia has the lowest rate of ulcers, diabetic foot ulcers, about 1.5%. Asia had a prevalence of 5.5%, and the highest still it was in Africa. We all know that are still underreported, which is 7.2%. Let's talk a little bit about global view of diabetes-related food complication in African sub-Saharan continent. This was a paper which was published just 2 years ago, which we looked into diabetic foot in last 60 years, 1960 to 2020. I'm going to show you a few statistics from Africa. Let's start with peripheral neuropathy. And you can see peripheral neuropathy, wherever you are in Africa, is almost similar what you see in Western world, between 5 to 80% in Western world, and is a similar what you see in, and it's a major underlying risk factor for ulcers and infection in our part of the world. And if you do the literature review, we are almost similar what you see in the Western world. So whether you go 20 years or 30 years back till 2002, we were similar with peripheral neuropathy. And when we did a comparison between Asian and African population, because we have the mixed population, the prevalence rate of peripheral neuropathy was similar whether you are Asian or an African. Look at arterial disease in Africa region. Peripheral arterial rates are increasing in Africa, and as I already said, it is increased because of urbanization. Rate across Africa are going upwards, and it's almost similar what we see in the Western world. Double digit. But if you see before 1991, we were almost single digit, almost unknown of arterial disease. So we have developed at the cost of health. So more peripheral arterial disease are becoming double digit, similar to what we see in the Western world. Even if you do comparison between African and Asia, before it was not similar, but now if you look at it, they are almost similar and not significant. Even we did a comparison with Caucasian population from Germany, African from Tanzania and India. This was a study done in 2003, which was published there. But at that time, neuropathy was similar. But if you look at the arterial disease, it was more in Caucasian population compared to African and Asian. So Charcot neuropathy was almost heard in Africa. But as our populations are now getting more awareness and the life is prolonged. Our people used to die of septicemia, but now we can see Charcot neuropathy, and you can see from Tanzania, one of the paper, 18% of Charcot neuropathy, and similar studies have done in Uganda and Egypt, about 12%. Time is tissue in diabetic foot. These are the diabetic foot which I see, and this is a diabetic foot attack. Is an emergency, has to be tackled. Because this patient initially started treatment at home using herbal bath, razor bread, then they go to the traditional healers, then they visit to the primary health center, then they go to the district or regional health center, and by the time they reach to the specialized center, it's almost difficult even to save the life. Forget about the foot. So look at the outcome admissions in African populations, and we can see that 54% of the populations come are almost late, Wagner more than 4, and die because of diabetic foot. And overall population in this cohort study, we found 27% of mortality. So high rates of amputation across Africa, if you look at it in last 10 or 20 years. Socio-economic factors. We still haven't finished in Africa with all these socio-economic factors: barefoot walking, inappropriate footwear, home treatment, tendency of seeing patient, herbal doctors, and then overcrowding leading to red bites. This is one of the patients who had come to us. We had gone to the herbal fat healer, and he told them that this infection, we should use your wife's scalp hair to reduce this infection. In the end, what happened? The wife lost all her scalp hair, and poor person lost his limb. This is a patient who was mixed with aspirin and dung. So these are still huge problem in our part of the world. D-Foot International, a mission with vision, and with urgency. Let me tell you about D-Foot International, our mission, goals, and focus of action, which are tailored to combat this war, which is globally we are facing. D-Foot International is a registered international non-profit association registered under Belgian law. D-Foot is an organization where all are dedicated to providing preventive foot care, and these people come across 7 regions, as I've already mentioned: Sub-Saharan, South Central America, MENA region, North America and Caribbean, Europe and Southeast Asia, and Western Pacific. Our mission to promote the global profile of diabetes-related foot complication, prevention, care through awareness, guidance, education, research, and professional development, ending avoidable lower limb amputations due to diabetes worldwide. It is a mission that knows no boundary and has impact on 1 million of people's life. The mission is not just a distant vision for us. It is a mandate, a call to action that demands the utmost emergency and urgency. Our goals is to prevent and reduce the number of unnecessary amputations from diabetes worldwide and improve the quality of their life. Our focus of action is training the healthcare professionals at the primary levels to manage diabetes-related food programs, giving healthcare professionals strategies, implementation, and how to sustain in the countries, promoting and recognizing of diabetic food specialty as a professional specialty in low and middle income countries. We in Diabetes in D-Foot International firmly believe in equipping the healthcare workers, particularly who are at the primary healthcare centers, because where the more population is there at the grassroots level with the knowledge and tool to tackle the diabetes-related food complications. Closing the gap of available and affordable diabetic food care. Encourage the program which are cost-effective and affordable to the universal health care. So, as I always say and would say again, education is the only powerful tool we have, especially in low middle income, which is free of charge for patients and effective if implemented properly. We have a moral and ethical responsibility giving back to the community and help those who are vulnerable. Several projects have been planned and equipped as a healthcare professional with knowledge and skills of excellent patient-centered. All this has already been started in these 2 years, 2023 to 2025. Our programs are all these flagship programs, and which is train the food trainer or train the food healthcare professionals, followed by step in each country. World Awareness Day, which we do it every year from 14 to 7 to 14th November, webinars, newsletters, and all these things which I'm going to talk in my little bit in this talk. Flagship program is a trend of we started in 2003 with step-by-step food project, which carried on for about 10 years. And then it was decided to go to the trend food truckers in 2012, which carried on till for next 10 years. And then we said that now we have all the awareness is there. So we decided that train the food healthcare professional from 2023. So when we train the food healthcare profession, they go and they do it step by step in their country. Most of the food problem, as I mentioned, 85 of them can be prevented through simple early identification and prompt treatment by skilled health professionals. And one of these was step-by-step food project, which started in Tanzania. The program showed that ulceration, infection, and limb amputations are potentially preventable. Any project you start, you have to hit hard and target. Step by step, which was started in Tanzania, and education is important. We have to also know who is educating who, otherwise the message will go upside down. It was a historical moment when this World Diabetes Foundation people, 9 of them staff, came in Tanzania, and it changed the way to look at the low and middle income countries. Same time, the program was proposed by them, and we did step-by-step project. The first one, which was done in 2003, and we had a basic and advanced courses, and about 9 programs were done in Tanzania. After looking at the success of step-by-step, then it was decided to go outside Tanzania. We also did a surgeon project, which was theory and practical sessions, which was in collaboration with Dr. Arun Bal, surgeon. They used to do theory, and then the life cases were shown from how to salvage the food from the theater. And these were some outcome from the surgeons. You can see where the food was completely necrotizing fasciitis, and it was saved. The effectiveness, we have to look whether step-by-step is working or not to reducing the rates of amputations. So we looked from 2001 to 2008 at the mean referral hospital, and you can see before that there was a high rates of amputation when step-by-step started in 2003 somewhere, and then it was a slightly peak during that time in 2004, and then it started going -2 standard deviation. This was then successful. Then it went to about 15 African countries and other outside Africa. You can see other outside Africa. But then we said that we cannot go to each and every country, 192 countries in the world. So the concept of train the food trainer came in 2012, where we said that we go according to the region. So 7 regions. In that region, all the countries, 2 doctors and nurses can come. We educate them, we train them, and then when they go back to their country, they do it step by step. In 2023, we started train the food healthcare professional, and because now we know that these are all the healthcare professionals are already aware of diabetic food problem. So the concept was training the program that teaches courses structure, organized delivery methods, and evaluation skill. And the course runs for expert to train others to become expert in clinical and education skills and knowledge. So there were 3 parts: basic, advanced, and then we also tell them implementation and data collection. And this is still going on. So the first train the food train courses in 2012 was done in 14 countries in South America, where all of them met in Brazil, and then they went out to their country to do step by step. The second one was done in Caribbean island, 22 countries came together. The third was done under the leadership of Vilma in Europe, Slovenia, where 17 Eastern European countries came in. And fourth one, 13 Western Pacific countries was done in Thailand. 13, then the fifth one was done in Marrakesh, where French-speaking countries, 13 French-speaking countries came under one roof to do this course. And the last, before COVID, we did it in MENA region, where 14 countries came in under this. And then the last year, we did it one in Southeast Asia, which was the 7th Train the Food Healthcare Professional course in 2003. Then it went back to South and Central America region. 8 countries were trained, and then they went back and did it step-by-step food project. Western Pacific, where 14 countries came under one roof in Malaysia, and they were trained, and then they were disseminated knowledge by step. We repeated again in Eastern European region, 10 European countries this year in February 2024, and then they went back, did the step-by-step, and we had a report very soon was done in one of the countries, step-by-step food project. And 11th one was done in Africa region, and this was my dream come true, where 11 African countries from 16 centers came in under one roof in Zanzibar, English-speaking countries, and they went and they are still doing step-by-step projects in their countries. The 12th one was done in a MENA region, which was mostly focused on war-affected countries in MENA region. 5 countries took part there, and then they are in the process of doing step-by-step food projects. So in my term, 5 were pledged, which have already been done. There are 2 more pledged. Western European region is asking for 13th Train the Food Trainer course or Train the Healthcare Professional course, and Sub-Saharan Africa, French countries. We hope that it can happen in April next year. So step-by-step food projects was actually for low-income countries model. Started in Tanzania, it went to the low-income countries, middle-income countries, and then it also went to Europe, high-income countries. So far, it has touched 128 countries where it has been implemented. So it's been a great success, and this is how awareness has been created for past since 2003 till 2024. It's more than 20 years. Other flagship programs is Awareness Week, which we do every year from 7th to 14th November. And this year we have already done this. We are already started. And today is the 12th November, which is European region. Webinars, every 3 months we have a webinar. These are the leaders in diabetic food, and they present the consensus, what were done in their field. So we have already done about 5 of them. The 6th one will be done by Professor Dr. Dan Wickton, which will be talking on the surgical aspect. Then we have Jen Epp, and then the last one would be done by Professor Siko. Partner organization. We have a whole partner organization. This is one of the proposals which we have been working, myself and Professor Beata and the board, International Diabetes Federation, European Commission, World Health Organization. This is what we are suggesting, that 4 organizations go together and do a program, an approach to 192 or 93 countries to get a commitment to save the amputations. So it's a proclamation on a diabetes-related food complication to scaling up the global diabetes response. Collaboration between global, regional institution and national government to tackle the burden of diabetes and its complications, and we can reduce amputations and mortality. Signing the common resolution from all the state members, this is our aim, and it should be done under the guidance of IDF, DFood International, and European Commission, declaring willingness to take the comprehensive measure to reduce incidence of amputations, mortality, and in each country. So our key commitment is healthcare authorities deliver the coordinated multi-level care tailored to the local resources in that country. Collaboration with DFood International and IDF. We have a regional chairs advising in collaboration with International Diabetes Federation Office. We provide evidence-based, validated and recommendations and tools. Training, the program for healthcare professionals, which I've already mentioned under the guidance of International Working Group of Diabetic Food to implement, as DFood International is the implementation arm of International Working Group of Diabetic Food. Implementation of the primary healthcare programs and need to emphasis on diabetes-related food complications, screening, treatment, and recurrence of prevention of these amputations and ending the mortality. So all these things has been visual, and we managed to do a signing with the initial stage with International Diabetes Federation, where we had a meeting in October, early October in Ivory Coast, where Professor Peter and myself, this is the first step which we took, Abidjan Pro-Action Declaration on Diabetes-Related Food Complications, and the next one we want European Commission to be a part of it, and then we go, all three of us, to WHO, and then we proceed to go further, where we can get a signatory from 192 countries. IDF has been working with us for a long time, and we have done several projects with them. All these things was done under auspicious with IDF, or sometimes international working group as well. So 3 of them. We have a very good connect together for a very long time. We work together, and Professor Fengem is now chairing the International Working Group of Diabetic Food. We have also produced all the info cards for people at the middle and low income countries, even high income countries, for the doctors and the nurses. They also International Symposium of Diabetic Food members, they also come. They came this year in February, and they did teaching at one of the Kilimanjaro Christian Medical University, KSMC, and they educated 54 delegates, which were targeting physicians, surgeons, orthopedic surgeons, and nurses. We have also good connection with International Association of Diabetic Food Surgeons. We had several meetings together and conferences. Recently, we had this 21st Diabetic Food Society of India, 10th International Association of Diabetic Food Surgeons, and 2nd D-Food International Conference in Mumbai, which was very successful, and where we all got together and declared that we're going to work together for the sake of benefits of diabetes-related food problems. Then we have a Limb Preservation Alliance, which is an alliance of 4 Wounds Canada, American Limb Preservative Society, and Canadian Podiatric Medical Association, along with D-Food International. And there's a couple of programs which we are doing at the moment with them. We have a newsletters coming every 3 months, and that's a 6th newsletter which came last month in October. Several projects we have done. I've already mentioned about the global course study, which is almost in the press to be published. Then we have an Aphrodite project, which 12 African countries got together, and we have a footwear project for low and middle income countries, which we looking for the footwears. Then we have auditing and benchmarking, where one of the delegate from a board member, Roberto, is taking care of this, and we hope we can finish this thing. We have rehabilitation and mobility technology for low middle income countries, looking at them, mostly assisting their people with diabetes in low and middle income countries. Fast track pathway has been started launching in many countries, and this was also launched in Pakistan, Karachi, where 150 health centers have got together to launch this thing. In China, we did step-by-step food project. In India and in KSMC was also done this year and last year. We have brochures in many languages. If you don't understand English, or you can go to the Chinese language or Portuguese or Spanish, all of them you can download from the World in D-Food International website. Then this was the conferences which we do annually. The first one was done last year in Malaysia. The second one was done in Mumbai this year in September, and the third one would be done next year in Malaysia again between 9th to 11th May, and where my colleague, President-elect Professor Harry, is going to take over from me. So, where do we go from here? In summary, many reasons for poor food care in various laws have been discussed. Increased high technology, rocket or genetic science will not change the practice, especially of diabetic food in low and middle income countries. So, if I have been asked, what will change the practice in next 25 years? Reply to this question is not high technology, but rather dissemination of knowledge. And it has been shown that prevention and knowledge can save 85% of amputation. So two distinct areas has got an impact. Powerful tool for prevention and control of food complication in less developed countries and empowering the healthcare workers. These are thanks to my staff, because without them I could have not reached where we are, and all the colleagues who are helping me around the clock. In conclusion, I deeply encourage each and every member of D-Food International to actively engage in activities. Your unique perspective, insight, and dedication is very important for D-Food International. Together, we can improve the life of people with diabetes. Together, we have a power to make a difference, and let us collaborate, inspire, and transform the field of diabetes-related food complication for the betterment of the patient. Last slide would be, I would to give you a message from a Holy Quran that knowingly or unknowingly, how many lives we are saving as a patient, as a doctor, saving the lives of the patients. So if you look at this Holy Quran, chapter 5, verse number 32, it says that save one life, you have saved the whole humanity. That means you get a credit of whole humanity. And at the moment, humanity stands at 8 billion population. But if you kill one person intentionally, it will be killing or getting a curse for whole humanity. That means you get curse for whole humanity, which I already said, which stands at 8 billion population. Thank you very much for listening, and thank you very much for all the work you are doing. Thank you. Thank you very much.
To the end of our meeting, thank you very much all the panelists, Professor Vilma Urbancic, Professor Roberto Anichini, Professor Abbas, who showed us the perspective of Diabetic Food International and showed us the global view of Diabetic Food International. Thank you, Dr. Adam Jarubas, and thank you all the participants of the meeting, among them Christine van Acker, who is listening to us, and she started many of the programs which were mentioned by the Dr. Abbas. Thank you very much, Christine, and all of you who do a lot within the patients with diabetic foot. And you will be sent the mail to join the activities related with putting the proclamation, signing the proclamation between Diabetic Food International and Euro Parliament. Thank you, all of you. Be with us.
Bye-bye. Thank you.
Bye-bye.
Bye.
Together we can do more. Thank you.
Bye-bye. Thank
you, and see you as quickly as possible.
Soon.
Yes.